First, let me say what a distinct pleasure it is to be here, and thank everyone for their kind comments. Knowing John through the American Burn Association, I think we were all tremendously saddened by his loss. We were both at that time on the board of the American Burn Association, and John was in line to become president of that organization, and I was sort of 2 years behind him. So his loss was felt greatly by all of us. I was involved in the early projects with advanced tissue sciences and out here in the 90s working with John, and his passion for doing things was just as everyone said, and it didn't take long to learn the greatness of him. But I thought the thing that was unique about John, people would say things, he'd listen and wouldn't say a whole lot, and then all of a sudden he'd say one or two things. And it really would show that not only had he listened, but he had been carefully analyzing it, and he had great insights. And so for me, this is really a distinct pleasure, and it brings back a lot of fond memories. I'm also kind of delighted to be here and add my congratulations to Dr. Hoyt, and also know how much you're going to miss him here, because some faculty, and I think David epitomizes that, eventually become the fabric of an institution. And it's kind of hard to know how you get those people actually out of here. You think you have to tear the buildings down and grind them up because their DNA is embedded in the campus, and I think David's somewhat guilty of that. I thought I would do this for Dr. Potenza, who's a Loyola graduate, and there are a couple of others in here I think who spent some time on our campus. This is where we are. It's flat. And this just gives you a little notion of the places that we live. We have kind of when I first moved there, it was kind of still the residuals from the old, this actually used to be an Army base, Grant Army Hospital that was there from the Second World War. And our university was looking to build its own hospital and get out of being under Cook County back in the 60s, and they were going to move, and for $1, the Jesuits couldn't turn down this piece of land for $1 from the federal government. So we lived juxtaposed to the Hines and so forth. So it's kind of a great environment for us, and one of our great opportunities is to be so kind of integrated for all of our operations, from our research to our medical school and everything, and it helps us do what we like to do. So just to refresh Bruce's memory if he hasn't been back there for a while. And also you can see why they keep on probably writing to you for donations, because they can spend money faster than anybody that I know, even my wife and 3 daughters. Today's talk will be a little bit of a departure from the typical surgical talk about how to do surgery and so forth. And I think for the students, what strikes me is when our students rotate in the burn center and they rotate on our critical care units, is I love the comment that's always made, you guys do a lot of medicine while you do surgery. And I think that's one of the things that somehow gets lost in the translation from moving from the basic science and the clinical lectures and the problem-solving cases to when you come to the bedside to take care of critical illness, you need to understand the science and the biology as it applies to sick folks and how we make them better. And that's kind of my romantic idea of being a surgeon is that you happen to be the only complete physician left, and that you can see somebody in the emergency room, you can put them in an ICU, you can care for them, you can operate on them, you can rehab them, and you take care of them for a long time. There aren't many people who have that privilege, and I think our privilege is relatively unique in that regard. But the issue is how you take care of people like this. As a 39-year-old school teacher trapped in a car when it exploded, and she had multiple injuries in addition to her 65% burn, inhalation injuries, she had ruptured small bowel, and extremity fractures, and the burns that you see. Is our care of this patient strictly focused at the wound? And the answer at the end of the day says yes and no. Because the key issue that we're faced with in dealing with patients such as this is to well understand that for the patient's wounds to heal, we have to allow the physiology to survive. And how do we support that physiology, and what's important to know about it? And one of the key things is to understand this very basic concept that people who have large cutaneous injuries have the severe metabolic response. And how do we understand it, and how do we try to remediate the process? And are there things that we can do other than just simply sit there and go, well, I don't know, you just need to give them lots of food and lots of calories and just kind of pour it in and assume that the black box machinery is somehow going to compensate for the severe perturbations that have occurred with the injury. It requires some dissection, knowing some history, and going back to the work of Sir Lord Cuthbertson, going back to some of the work by Franny Moore, and going back into history and understanding some of the important things that have been discovered about the human response or the mammalian response to injury. That really, there is this sort of phased response as someone is critically injured or has critical illness, and how they adapt and how they respond. And if we're not cognizant of the time-dependent response, our treatment cannot be congruent with the patient's biology. And for sure, this is the part that we focus on the most, but it's also understanding some of the things that occur in here that allow us to get here so that we can take care of patients who've been critically ill. And if we don't pay attention to some of these early phases, we really never get a chance to get here very well. The flow phase is the one that's mostly talked about. It's the thing that we mostly focus on because that's the time that we think we have the patient now resuscitated so that we can do what we want. And it's typified by this hyperdynamic circulatory state and this elevated hypermetabolic rate. Two simple concepts, and to some degree one could decide, is this simply a reflection of the need to support this? So is the circulation there because it's hyperdynamic, or is it because we have this elevated hypermetabolic state and the circulation is simply required to be there to support what's necessary? And if you look at this time-dependent curve in terms of the cardiovascular response, and we don't tend to think about this very much, but it's pretty clear that if you go back and look at some of the basic biology and look at cardiac performances our labs have done in the past, that you go through a period of time where one sees actually an elevated peripheral vascular resistance and in fact sees a depressed cardiac output in the early phases. Failure to resuscitate will leave a patient, or inability to resuscitate correctly will leave a patient trapped on this portion of the curve. Whether you believe in myocardial depressant factor, as Charlie Baxter wrote about some 40 years ago, or now more recently the work by Jarita Horton following in Charlie's lab looking at cardiac myocyte TNF production, we know from our own work that TNF elaboration interferes with cardiac performance and particularly relates to the velocities of relaxation of isolated hearts, and then in fact it relates to changes in myocardial performance due to changes in compliance. But pretty clearly, if you can at least support the resuscitation and be judicious about fluid management, which seems to have become a lost art. Most of our patients seem to always want to turn into lily pads these days when we look at the volumes of resuscitation fluids that are given and the whole issue of abdominal compartment syndrome, which is mostly iatrogenic, is that failure to judiciously manage fluids can cause just as much of a difficulty. But the ultimate goal of the resuscitation is to get the patients through this scissors phenomenon. And it's the point is that we eventually need to see their peripheral vascular resistance fall. We need to see this substantial elevation in cardiac output for patients of burns of 40 or 50% body surface area. The reason the heart can have this 12 to 14 liter cardiac output for day after day after day and not develop cardiac myopathy is really related to the fact that it's doing it against a relatively low pressure head. So the rate pressure product is relatively reduced and myocardial oxygen consumption is not as great as one would expect, although it's still critical in these hearts because it's not doing pressure work. Remember, the heart can do volume work. It doesn't like to do pressure work. And as long as it can do volume work, it can do this in a relatively judicious way. And again, one has to look at this and say, well, this goes in hand with the increases in metabolic rate, and how much of this, again, is a secondary or primary phenomena. We also understand that the increases in metabolic rate are not just simply related to the event, but they're dependent upon the time that the event goes on. And differently in this class of patients than other injured folks, it doesn't stop. As a matter of fact, if you look at resting energy expenditure in substantially burned patients, it may take them 9 to 12 months to come back to normal. And that's the other end of the curve that we need to understand in our rehabilitation of patients who we presume can go back to work because their wounds are healed. Their resting energy expenditure still remains elevated for many months. And the majority of your resting energy expenditure is, in fact, the majority of your daily energy expenditure is related to sitting still. Most of us aren't out chopping trees down every day. And so most of our work is glandular work. 50% of the calories that are taken in are used to generate heat. So it's not a very efficient machine unless you believe that part of the body's response is to be a thermogenic pump, and that certain systems work better at a given core temperature than they would if we allowed the human body to be a poikilotherm, and that really doesn't really fit the efficiency of the machine. So we run in a relatively narrow thermal tolerance, but if you have still wounds that while they're healed, they're still inflamed, you're going to have this persistent increase in resting energy expenditure despite the fact the wounds are closed. And that's another piece of the thing that we have to think about, is that the tail of this curve is phenomenally long. And then finally, the issue of that with burns, it's really pretty much of a straightforward dose-response, near linear relationship between the magnitude of the injury and the relative increases in the resting energy expenditure. And post-operatively, patients don't have significantly great perturbations in their energy demands. And even with single bone fractures, while there's an elevation, it's relatively finite. It's with these larger burns and anything along the way that there's a significant enhancement in the need for support. Again, this is all a derivative process of the injury. And it begs the question, is this something simply we have to support, or if we understand the biology behind it, can we interdict it and can we start to manipulate it? So we need to be mindful of the issue that there's about a twofold, maybe not quite that high, but somewhere in the 170, 100% increase in basal energy expenditure as a result of injury. This is clearly associated with an increase in oxygen demand, hence the need for patients to have optimum pulmonary support. There is increased substrate oxidation. You don't have an increase in energy if you don't have something to burn. Something needs to burn in this fire to support the energy demands, and it will either come from external or internal sources for some period of time. The oxygen consumption is basically related to an increase in total energy expenditure. That is clearly the issue. Changes in increased utilization occur in the liver and the skeletal muscle precisely as a consequence of the injury and the inflammatory milieu that exists. Because this elevated energy expenditure is associated with an increase in substrate oxidation. That's an obligate response. Part of how we see that our patients have elevated core temperatures. Everybody wants to run around and culture a burn patient with a fever of 38.5. That's not abnormal. That's normal. That's where they need to be. They want to run at an increased temperature. Why might that be evolutionarily? One, anybody who took chemistry remembers if you want a chemical reaction to go faster, heat it up a little bit. It's called the Q13 effect, or we refer to it as the Q10. You want an increase in the efficiency, run it at 1 degree hotter, it'll go at about a 10% increased efficiency. Turns out certain bacteria have relatively normal and very tight thermophiles in terms of where they want to grow. Temperature is also somewhat of an antimicrobial response. And certain bacteria don't like the increased temperature environments in which they live in. So it's somewhat of an adaptive response. When I first went to Loyola, there were all kinds of cooling blankets all over the place. One of those hasn't existed in 16 years. I banned those. And the notion of opening the windows, so to speak, to cool patients down, as I'll show you in a bit, was simply an inability to understand that an increase in temperature really represents a reset in the thermoregulatory mechanism, but in part it's related to this need as well. So it's an adaptive response, and we need to understand how to support adaptive responses. During this flow phase, it's pretty clear that we have a lot of things that seem not to make sense to us. Why would the body do this? We have increases in fasting serum glucose. We understand the hyperglycemia of illness, but that's in the face of increases in circulating insulin levels. That doesn't seem to make sense. There's this obvious insulin resistance. There's a decrease in the rate at which glucose disappears from the circulation. There's an increase in delivery of glucose to peripheral tissues, but the net effect is a decrease in glucose oxidation. There seem to be these paradoxical events occurring. And are some of these designed to occur, or is this a manifestation that we now have patients that are injured beyond physiologic reserves that will allow them to have survived a tiger bite or chased by the leopard or getting stabbed by one of the local cavemen over a dispute? And so are we really now in a phase of decompensated human physiology that we as the physicians are trying to get inside of and right this machinery that in fact would otherwise lead to death? Post-injury, there's this increased glucose need despite increases in plasma glucose. Where is it going? Well, we know in general the brain is an obligate user of glucose, and only in profound starvation will the brain eventually be able to switch to using fatty acids as a nutrient substrate over some extended period of time, but particularly most of the glucose goes to the brain. We know leukocytes have a particular need for using glucose as part of its basic energy metabolism. The renal medulla has a high requirement. And in injured patients, we have this new phenomenon called the wound, that it has pretty much a selective carbohydrate diet and uses that. Now, part of that may be well related to the inflammatory component that's in part of any wound. I would also remind you that lactate, which we'll talk about in a moment, is a key signal in the whole wound healing process and drives much of the response that occurs in the wounditis. The whole issue of the insulin and the insulin response and the hyperinsulinemic response is somewhat of an intriguing thing. First is understanding a little bit about the biology of the insulin receptor. It's a heterotetrameric transmembrane glycoprotein. It's got two extracellular alpha units where the insulin binding domain exists. And then there's this key transmembrane portion where the tyrosine-specific protein kinase sits, or the insulin receptor kinase sits. And it is really in understanding some of this biology that makes things a little bit clearer and where some of our problems are. The whole notion of insulin signaling for insulin-sensitive tissues is that with insulin binding, the IRK autophosphorylation occurs, giving an activation within this that allows the insulin receptor substrate phosphorylation, which is responsible for signal propagation. Sounds like a mouthful. I'll show you a cartoon in the middle that understands it. So if we think of this here as being this tetrameric configuration sitting on the membrane of insulin-responsive tissues, the typical normal physiologic response is that with insulin stimulation, appropriate phosphorylation of the IRS, the insulin receptor substrate response unit, one gets insulin signaling and the changes that one wants as a consequence of that. And it also sets the stage for negative feedback control, which is a physiologic response. Then there's pathologic arc that in fact does represent insulin resistance. So the insulin resistance can occur at two levels. At the receptor level, we know that epinephrine and glucagon, part of the normal hormonal response to injury, and if one in fact looks at some studies done by Doug Wilmore a number of years ago, where before the cytokines became sort of the molecules du jour, and Doug's original studies looking at triple hormonal infusions to try to recreate the hormonal milieu, you could add epinephrine, you could add catecholamines, but it wasn't until you added glucagon into the mixture that in fact you got the prototypical response. So epinephrine and glucagon cause changes and increases in cyclic AMP-dependent protein kinases, and in fact catecholamines do this in lots of cells, including actually within the bone marrow as well, as some of our work has shown, that catecholamines typically changes intracellular cyclic AMP. This leads to changes in cyclic AMP-dependent protein kinases, leads to an abnormal phosphorylation of the insulin receptor, leading to this insulin resistance. And typically, as we understand, if you look at these in the laboratory, looking at gel shift assays and so forth, that you can see that phosphorylation in terms of what occurs in terms of serine and threonine within the receptor is critical for its lack of responsiveness. What happens downstream, though, is interesting because now TNF-alpha comes into the picture so that we can see this synergy that occurs in the more traditional and sort of more primordial catecholamine and glucagon response, sort of the hormonal response that now starts to go hand in glove with the inflammatory response. And that TNF-alpha causes changes in insulin-induced tyrosine phosphorylation of the IRS, the insulin receptor substrate, changes to additional changes in the IRS, which leads to an impairment between the binding of this receptor with the juxtamembrane portion on the insulin receptor and basically blocks signal transduction. So we have issues in terms of insulin binding to the receptor, and then we have issues in terms of signal propagation. So if we're going to attack this problem of hyperglycemia, which, as we know very well from the Vandenberg group, is key in having good outcomes in critically ill patients, we need to understand where we're going to kind of interdict the process. Because this is where probably the majority of the problems occur in burn patients. We know we sort of have this up here, but we also understand that this is probably another opportunity for us to look at fixing the defect. Hence, we see these patients that are critically ill, that we're trying to support their significant nutritional needs, and all of a sudden we're running insulin drips at 200, 300, 400 a day, and people are losing their mind about how much insulin we're giving to the patients. And then when our endocrinologists come and try to show us, we went to these protocols for controlling glucose in our patients. So they had a 1, 2, and 3 sort of paradigm. When they got through with us, we got up to 6. Then eventually the endocrinologist said, I think you understand what we want. We'll be back. And they haven't been back in a year. And just kind of leave us to our own devices because we kept on breaking the mold of how we ought to do things. But this provides us an opportunity to create strategies to look at where we can, in fact, remediate this process. One of the other things that's important to understand is in our desire to feed patients, do we need to do this in a physiologically/pharmacologically appropriate way? We would presume that we just ought to give them all the calories we can. This still is a bit of a debate as to how you ought to do this. But this is stuff done by Bob Wolf when he was still in Harvard back in the late 70s and early 80s, looking at maximum glucose oxidation or disposal. There is a fixed rate at which you can burn carbohydrate substrates when you're ill, and it's not limitless. And what it turns out is that in a severe burn patient, the maximum glucose disposal, that is going through to be burned and to be used, not going into fat synthesis or causing hyperglycemia, but truly being of metabolic importance, is relatively reduced. And it's related to some of the things we just talked about. You can only force so much through the system when it's dysfunctional. And the number of calories that you can give the average 70 kilogram person as a result of carbohydrate loading is less than what you could do if they were relatively not so ill. So there's another change that needs to fit into this, and if you're not mindful of this, as we'll talk about in a minute, you can make your patients sick. We sort of understand that from hyperglycemia, but you can cause some significant other problems. Because post-injury excessive glucose infusions augments production of the counter-regulatory hormones. We see that these things are ramped up, and you can in fact relate these to the rate at which people are being glucose loaded and being caused to be substantially hyperglycemic. The other problem we need to deal with is the increase in proteolysis of skeletal muscle mass. Elegant studies done back in the 70s, with split leg studies done looking at changes in what happens in extremities that are injured as well as what's happening on a body-wide basis. Nevertheless, we see in our patients, if we don't work aggressively, substantial loss of their muscle stores. It's as a substrate for gluconeogenesis and the synthesis of visceral and blood proteins, and this whole issue of hepatic protein reprioritization. This little sort of block diagram, I think, helps me understand what the issues are as it relates to things. Under the stress of things such as insulin and catecholamines, there's changes in terms of what happens in the skeletal muscle mass. Remember, this turns out to be the primary glycogen stores that are available to the body. The liver tends to keep pretty close control of its own and not necessarily allow these to be available widely for body use. It's really your peripheral stores that are maximally available. And this is part of the problem in our small children. They have relatively limited stores of these. Nevertheless, most of this 3-carbon substrates that are going to come forward to essentially go back for the synthesis of new glucose through glycogen really come from the skeletal muscle mass. And under the aegis of the Cori cycle is where this cycling occurs, really, and the enzymes of the Cori cycle are relatively induced by these compounds here that are part of the typical post-injury response. The difficulty in all of this is despite the fact that our wounds are oxic, the metabolic construct that occurs in the wounds is in the state of an anaerobic state, i.e. you get lactate. You get relatively limited generation of energy as a consequence of this, and most of this, if you look at increases in limb blood flow and increases of glucose utilization in the extremities, it's pretty much at the level of the wound. It's not here, it's at the wound. So the wound is part of our problem, or is part of our need to fix, that the wound is really directing this. And in some ways, you can think of the wound as like a fetus and a pregnant mom. It takes over, it becomes the boss, and directs much of the perturbations in the physiology that are going to occur. Additionally, we have to deal with the issue of lipolysis and fat oxidation. And this occurs despite increases in glucose. And again, remember, fat is a primary energy substrate for the heart. Only second to oxygen is one of its primary nutrient needs. And that fat is also burned in skeletal muscle mass as well. But we have this occurring at an accelerated rate. We have this issue of substrate cycling, of which opposing non-equilibrium reactions are catalyzed by different enzyme systems are simultaneously occurring. It seems illogical and sort of this bizarre departure from what we think is truly what exists in health. So you have lipolysis with reesterification occurring at accelerated rates, breakdown of glucose and the reformation of glucose, and then the issue of the fructose cycle. And it seems all sort of a waste of time, although I would also remind you that each one of these cycles generates heat and supports the thermal central environment. The fact that this is really just a departure from normal health actually is not correct. If you typically look at what happens in the liver in this issue of zonation of carbohydrate metabolism, it's pretty clear in the post-absorptive state, when carbohydrates are taken in and they go relatively into the perivenous hepatocytes, that in fact what you see occurring in the liver is this issue of glucose being taken in, being used relatively inefficiently in this zone in terms of the perivenous hepatocytes, lactate production, and the lactate actually recycles back to the periportal hepatocytes, where in fact now lactate is cycled back into glycogen. And this is the thing that occurs when you eat. And hence the importance of the relative, how you strategize feeding patients. Why there is a notion to why the enteral route is superior to trying to do it parenterally is because we need for this kind of process to be able to occur, and it really is a portal-dependent process. In contradistinction to the post-absorptive phase, where in fact glucose comes in, goes into the circulation, combinations of lactate and alanine coming in from skeletal muscle mass is how you create your glycogen stores, or in this case, synthesize glucose and glucose back into release. And so that there is something very unique about this pathway and very uniquely related to the route of nutrient administration. Hence, those of us who've become essentially total devotees of enteral feedings. and see the fact that we have to hyperalimент our patients is really a failure of our care of patients, and that in the end of the day begins to not only explain some of why nutrient utilization is so much differently when you feed people enterally, but the whole issues of the gut. And I know Ed Deitch was here previously and spoke about this, but our own work coming out of the laboratory as well shows that the GI tract is critical to preservation of immunity, since every white cell in the body eventually goes to the GI tract as part of its priming process, and what happens in the GI tract is equally an immune response as it is a digestive response. So if we kind of put this all together and look at some work that's been done, and now this work is almost 20 years old, but it's still as good as it was, in terms of looking at things like fatty acid cycling, and in fact you see that occurs in patients with burns at an accelerated rate. And then if you look at over here in terms of the glycolytic and gluconeogenic cycling, that occurs at substantially increased rates in patients with major burns. So this occurs. Part of it is related to heat. Part of it is related to the fact that you need to support the central store in terms of energy needs, and part of it is related to the inflammatory response in the wound being present. But this is part of the adaptive response to the injury. So if we're going to alter the metabolism, what things do we have available to us if we understand some element of the biology? The issue of non-pharmacologic approaches, and then what can we do pharmacologically? Well, some of the non-pharmacologic approaches are pretty simple. Early excision and wound closure is key. Prompt treatment of sepsis, nutritional support via the enteral route, and then the issue of the environment of care. Early excision should be related to a relative decrease in metabolic rate. We know that getting the eschar off in patients that are critically ill, covering them with something, whether it's Integra, covering them with Transcyte, getting them grafted, reduces metabolic rate. There's a reduction in skeletal muscle mass. And obviously the risk of infection goes down, which causes our patients further harm in terms of their ability to survive, but also in terms of dysfunctional metabolic response. Prompt treatment of sepsis is key. Preservation of the immune response is a consequence of that, modulation of the hypermetabolic response, or further modulation. And obviously we cannot add the insult of infection to further tissue loss as it might occur. The hence then of early recognition, prompt institution of appropriate antibiotic therapy, and understanding the microbial surveillance cultures from your unit. The whole issue of relative preservation of lean body mass, we start, as most people do, their nutritional support synchronous with resuscitation. Some argument about whether that's so necessary. Our notion is the small bowel never sleeps. It's like a surgical first-year resident, and that's key, and that it may have some effect on altering the metabolic response, but at the end of the day, a happy gut is probably a gut that's going to serve you better than one that's unhappy. And if you don't feed it, endoluminal nutrition is critical to the preservation of the GI mucosa. The environment of care is critical. This is a composite curve that looks at a series of studies that looked at the relative impact of body surface area burn and metabolic rate dependent upon the environment of care. Why are the operating rooms 90 degrees? Why are the units heated? Why are the tank rooms heated? Because if you take the standard perturbation of the injury and add the insult of topical cooling to the patients, you can see that simply the environment of care causes a significant increase in the resting energy expenditure in these patients. Something as simple as allowing them to get cold. And we're responsible for this. We have to control these environments, and we have to learn how to live inside these environments, because we can add insult to the injury by simply allowing these patients to be cool. Again, it goes to the issue of why someone who's out here with an increased metabolic rate and an increased temperature, in fact, wants to live there. Studies done a number of years ago who took patients who were critically injured and gave them the thermometer, set the room temperature at about 88 degrees. That's where they wanted to live. That's where they felt most comfortable. Same way, if you're in Chicago and you go swimming in January, you get out, you don't want to sit too long down on the beach. You're wrapped up in a hurry, or you're going to be doing this. Problem with our small children is that adults at least can shiver. Small children do not have shivering thermogenesis, and so they are very, very prone to this rapid loss of not only their temperature, but their ability to maintain it. So you go the other way. And here's the consequence of what happens in two classes of patients, one with a relatively large burn and to some degree operating already out at the end of their physiologic reserve. If you drop their environment of care, eventually they hit a negative inflection point. They cannot maintain their metabolic rate. They become hypometabolic. They become hypothermic. And interestingly, if you look at changes in their urinary catecholamine excretion, you can see the stress that in fact happens as a response to their illness. They can't adapt to it. People that are not quite so badly burned that still have some physiologic reserve left can in fact ramp up their catecholamine excretion, Catecholamines, again, will cause more uncoupling of oxidation, increased heat generation, and the consequence of that will be that they can relatively preserve their core temperature because they can drive up their metabolic rate. But you can basically allow somebody to get terribly ill by allowing them to get cold. Our biggest challenge is coming out of the operating room, having anesthesia keep the patients warm, not allowing them to get cold. Understand that we've got to operate fast enough so that they don't get cold, and have all the things available that cause the medical students to pass out during the case and fall to the floor because the room's too damn hot and they didn't eat and they didn't drink enough liquids. But seriously, when we try to look at what we can do to help our patients, is to understand the biology of which they're facing and appreciate that we may face it for 2 or 3 hours, they face it for the next 9 months or a year. And we have to be willing to accept that if we're going to allow them to survive. So if we move away from some of these relatively simple strategies and start to say, well, what is the pharmacopoeia available to us, we really can find a host of agents that have been tested in various ways, and then we try to sort out whether any of these really allow us to do anything on a practical basis, on a day-in and day-out basis. I've already talked about the stress-induced hyperglycemia and altered insulin receptor sensitivity. So we can look at something like metformin, a relatively simple compound. It increases insulin receptor sensitivity. It decreases net protein anabolism. It decreases gluconeogenesis. It increases peripheral glucose disposal as it relates to an oxidative fuel and a muscle energy substrate. Seems like something we might want to try to see if it would work in these patients. In a recent study from Gore et al., published in the Annals of Surgery, in fact, has done this. Now, most of this is in pediatric population, but it's been carried over to the adult population and seems to have similar effects. And what you can simply see in this study here in patients that were treated initially with a placebo compound and then subsequently in a crossover design, were able to show a change in the fractional synthetic rate for muscle protein synthesis by simply giving these patients metformin on a daily basis. The other thought is, what can we do in terms of hepatic protein synthesis? Well, we need to understand what's wrong first with hepatic protein synthesis. There is a reprioritization in the liver. The liver stops making the constitutive proteins. It tends to make a lot of these acute phase responses, and it makes a tremendous amount of fibrinogen. That's always sort of a key question that gets asked is, well, why does the liver make fibrinogen? Well, it's to stop bleeding. Well, bleeding's over in a day or two. Why would you still do that? Well, as it turns out, if you go back to the wound, fibrinogen is a key substrate in wound healing, the fibrin, that needs to be deposited there, and that's the substrate that keratinocytes most like to grow on, and grow on it very well. So part of it is related to the liver understanding the presence of the wound and the needs of the wound to eventually heal. So if we look at it in terms of the hepatic acute phase response, what we see is that in terms of changes in terms of hepatic protein reprioritization, it really is in large measure related to changes that can occur in terms of the inflammatory milieu. Changes through either TNF or TNF-related compounds and IL-1 and then IL-6 in terms of the consequences of working through these different pathways in terms of type 1 or type 2 genes within the liver and the differences that are changed in terms of compounds developed as opposed to the standard things that we think about that the liver ought to spend its time making, such as albumin. We know that human growth hormone has benefits. It can improve hepatic acute phase response. It actually is associated somewhat in the decrease in TNF and IL-1 in circulation. It causes a decrease in type 1 acute phase proteins, changes in muscle protein kinetics, muscular growth, and donor site healing. From a variety of studies, this information can be pretty much summated in this way. But its risks, hyperglycemia, and in a recent multi-center trial out of Europe, given to adult patients, it caused increased lethality in mixed ICUs. And so currently, while it was used very aggressively early in the 90s, particularly in the pediatric population, most of us are not using it this way. Besides, it's awfully expensive. I caused the pharmacist to lose his mind when we started giving growth hormone in this way, which was equally enjoyable. If we look at a way to try to get around some of these things, IGF-1 and IGF-1 binding protein have a construct that's been available. Currently, it's not readily available. It has similar effects in terms of modulating the acute phase response. Additionally, it's anti-apoptotic and it's pro-mitogenic for a variety of cells that we would like to see do well during this period of injury. And this is it was a randomized trial that was partially completed looking at this in a multi-center trial, which we participated in attempts to try to determine its impact on patient outcome. And it appears that this would be a compound that would offer us an advantage. So then we can sort of look inside of this box and decide are there other areas that we can work, and that would be the notion about whether we could cause changes here, maybe in less invasive ways. We understand that insulin itself prevents muscle catabolism, it preserves lean body mass, and euglycemia is associated with a decrease in infection and mortality. Most of this work initially coming out of the Vandenberg group, and now multiple centers have contributed to this wealth of information. Its non-carbohydrate effects are anti-apoptotic. It's a growth factor, preservation of innate immunity, reversal lipid profile, preserves hepatic mitochondria. It's anti-inflammatory, and it reduces endothelial activation. This is taken from a paper last year in the Journal of Clinical Investigation from the Vandenberg group, trying to understand in their patients who died, and they explanted their livers and looked at in terms of what the hepatic response was. And this is the notion that they developed. In states in which hyperglycemia does not exist and there is sufficient insulin, one gets a favorable induction of endothelial nitric oxide synthase, and that this is associated with a favorable profile in terms of having an appropriate amount of nitric oxide available. Conversely, when insulin is insufficient and hyperglycemia exists, some of the activations of NF-kappa beta that we talked about before in looking at the liver occur. This causes a relative induction of the inducible form of nitric oxide synthase, leading to high amounts of nitric oxide, and as it turns out, then potentially a series of catastrophic events occurring with increases in reactive oxygen species and cellular injury. We actually did some studies a number of years ago, which published in the Journal of Trauma, looking at nitric oxide levels in patients and trying to correlate that with survival. It's clear that in burn patients, as the magnitude of the injury goes up, so does the amount of nitric oxide released. At that time, we should have probably, if we had understood this data, we might have tried to make those kinds of correlations in those patients to understand whether it was an adaptive response or actually being driven by some of this effect over here, because in those days, we figured blood sugars of less than 220 were probably okay. And as you know today, the goal is to be less than 110, if that's humanly possible. Still is a question in my mind. Oxandrolone, we know that it allows people to get home run records. The question is, does it allow these patients to hit a home run? And so it increases net protein muscle synthesis, it increases lean body mass, increases bone mineral content, and it increases overall body mass, so that it may be something that we could think about using in these folks. There was some suggestion back in 2001 looking at patients that were either treated with a placebo control or treated with oxandrolone, whether in fact it could put our patients in some level of positive nitrogen balance. Remember, in most critically ill patients, our goal of nutritional support while they're still catabolic is to get them to zero nitrogen balance. It's pretty hard to put sick people into positive nitrogen balance. When our patients go into positive nitrogen balance, it's because they're actually getting better, not because we've gotten smarter. We give them the same calories, the same protein, and now their convalescence curve has kicked in a bit, and now they switch into positive nitrogen balance, and we take all the credit for it. It's finally the ablation of the inflammatory response. But in this group here, there was able to be a suggestion not only getting back to baseline, getting back to zero loss, but in fact a suggestion for increase in synthetic rate by looking at phenylalanine incorporation. Well, that was fine, but the most recently published in the Journal of Burn Care and Research is this multi-center trial from the American Burn Association. Closed a bit early, so one might challenge some of the outcome, but it was pretty clear that they were able to show a positive effect long before they got to the enrollment numbers that were predicted by the statisticians, to show that adults given oxandrolone, in fact, had a reduction in the number of days that they required to be hospitalized. And you could say, well, that's because some of the ones died and you vetted those out of the series, or maybe it was related to other things, different burn sizes. So in fact, the challenge to them before we published it was to go back and recompute the data. And what you can see here is if you adjust it per body surface area burn, you still get a good outcome in terms of oxandrolone. Living and dying isn't a good enough indicator anymore. Our outcomes in patients these days are such that living and dying is not enough fidelity in looking at enhancements in performance. You've got to look more sophisticated. Now, this isn't a terribly sophisticated study, but I think it does address the issue based on understanding some of the biology from other works and basic science data, that this probably is a viable compound to use. It's relatively inexpensive, and it's not associated with any significant side effects. That's kind of been our standard of treatment in our unit for about the last 8 or so years of using it both in adults and children. The other piece of information which I think is probably going to be the next horizon is the use of beta blockade. It's associated with obligatory changes in thermogenesis, changes in resting tachycardia, cardiac work, resting energy, peripheral lipolysis, and hepatic fatty infiltration. Seems like the wonder drug, that it can do all these things. And this is some stuff published by Dave Herndon back in 2001 in the New England Journal of Medicine that basically looks, again, at a pediatric population in terms of what happened in terms of baseline expenditure in terms of calories, and then what happens in beta-blocked kids. And that you could reduce from this, so the net swing was about 500 calories a day in terms of energy expenditure by basically blocking these kids' heart rates to about a level of 20% of their maximum heart rate, with the notion that was kind of the phantom for everything else that wanted to be done. Currently, several of us are getting together to try to do a randomized trial in adults because this has not been proven and whether this will work in adults. Our notion is that it will have a positive effect, but David and I are trying to design the protocol now to do this on a randomized multi-center trial. And in fact, when you look beyond some of these events and looked at what had happened, again, with muscle protein synthesis, you can see that by 2 weeks, just by simple beta blockade, about a 20% reduction in resting heart rate, one could, in fact, have these kinds of changes in terms of muscle protein synthesis by using a very simple compound in terms of beta blockade. Causes some problems in patients that have pre-existing asthma disease or asthmatic or reactive airway disease, and that's occasionally caught people a little flat-footed. An interesting effect is what it's done on fat-free body mass, that is preservation of lean body mass. Didn't make it positive, but it certainly made it a lot less negative, so you don't see these spindled extremities with this sort of central adiposity, because what we're trying to do is really preserve skeletal muscle mass. There's now trials looking at this out for a year in kids because of the problems with growth and bone formation in children. So at the end of the day, we can simply look at this as this kind of giant box over which we can just shake our head and say we don't know precisely what to do, or decide to start to disassemble the components of it and look inside of it, and decide that it's important to maintain, we need to support this, we need to understand these events, we need to control a lot of these other phenomena, we need to understand these things right here that are ultimately in our control, is how we take care of them, how we manage them, how we appropriately support them, if in fact we're going to try to support the wound and its ability to close. Equally, we have to understand the interrelationships that occur between things that we can do on this side of the aisle that in fact we can interdict the process and use things like pharmacologic agents in our surgical techniques to improve outcome. We can look selectively at ways to facilitate wound repair and regeneration. And clearly we need to be mindful of the standard and traditional approaches that we have at our disposal, because while our patients don't get here so often, I would challenge you to say once they get into that multi-system organ failure box, our ability to salvage them isn't a whole lot better today than it was 30 years ago. We don't have liquid lung. We don't have liquid kidney. We still don't have those things. And when these patients get profoundly, with more than 3 systems fail, our outcome is still not a whole lot better. Because we need to get them out of the systemic inflammatory response syndrome if in fact we're going to go ahead and have patients that can recover and survive. And that really is, at the end of the day, what our job is. And so what it says is if you're going to take care of sick patients like this, you need to have a longitudinal plan. You need to understand what you're taking care of. You need to understand it's like fighting a battle over the next 2 months, 3 months, 6 months. You understand the biology, the changes in the biology that occur over time. And like our medical students say, yeah, we do a lot of medicine and surgery, because that's the only way you're going to get somebody who's going to walk out the door and come back and then get back to their life and their family. So while we don't have a beautiful ocean to look at in Chicago, we got a pretty neat lake, and we got a pretty neat city. And out the window of the Burn Center at sunset, this is what or early morning sunrise, this is what we see someday. And if there's ever been a Gotham City, I think this is it right here. So I really appreciate the opportunity to come and visit with you today, and I consider it a distinct honor to have given this lecture. Thank you very much for your gracious hospitality.